So, good evening, everybody. At the outset, I thank Dr. Akash Kumar Singh and the whole Gujarat team, Dr. Sanjeev sir, for making me a part of this conference. So, hypertension in diabetes, this has to be discussed. So, first of all, greetings to all of you from Bangalore. So, if you take these two combination of hypertension and diabetes, it's a deadly duo. Hypertension is the most common comorbidity in patients with type 2 diabetes. The prevalence of hypertension is higher in patients with diabetes than in the general population. The coexistence of hypertension and diabetes increases the incidences of CVD and mortality and augments the risk of nephropathy and retinopathy. If you take the prevalence, if the prevalence of diabetes in India is 11.4%, hypertension is 35.5%, the prevalence of hypertension in diabetes is 37%. So, if you take the burden of hypertension and diabetes, ICMR data you can see there are 315 million people had hypertension, 101 people had diabetes, 136 million had pre-diabetes in India. Up to 50% of cases of hypertension are also diagnosed with type 2 diabetes. So, patients with diabetes shows 1.5 to 2 times higher prevalence of hypertension than those without diabetes. The risk is higher in elderly patients. After all these things of new molecules, new data, new things, whatever we are discussing, it is only saddened to see only 36% of the patients achieve HbA1c target and 48% hypertension patient achieve their BP target. You can see here. So, this is the one thing. So, we need to be aggressive from the beginning, educate the patient and so that the blood pressure is controlled from the beginning, blood sugar is controlled from the beginning. In the long run, they have a legacy effect and will be able to postpone or prevent morbidity and mortality. So, if you take the risk factors, there are modifiable risk factor and relatively fixed risk factors: smoking, diabetes, dyslipidemia, overweight, physical activity, inactivity, unhealthy diet. Relatively fixed risk factors are CKD, family history, increased age, low socioeconomic status, male sex, OSA, psychological stress. Bottom you can see in diabetes, 40% are hypertensive at the time of diagnosis and one of these patients has high BP before the onset of moderately increased albuminuria. So, what are the factors favoring hypertension in diabetes? One is the increased sympathetic tone, endothelial dysfunction. Hyperglycemia stimulates intrarenal production of angiotensin II with increased salt and water retention at the proximal tubule and genetic factor. You can see how the combination, the dynamic duo of diabetes and hypertension plays an important role in the important onset of microvascular disease, heart disease, peripheral vascular disease and even the stroke. So, 40 to 80% of the diabetes have hypertension and diabetes are 2 times likely to develop hypertension. So, diabetes and hypertension, what is the relationship? You can see one is the genetic factor, which leads to acquired factors, central adipose tissue, ectopic lipid, environmental factors, diet and exercise leads to insulin resistance, inflammation, hyperglycemia, dyslipidemia, hyperinsulinemia leads to vascular dysfunction, sodium retention, increased RAS and a sympathetic nervous system, hypertension. So, how closely linked to each other? The both are linked to each other. So, the identifying and addressing both the issues is very crucial. So, the impact of hypertension and diabetes in CVD, you can see the red one is the hypertension and diabetes. If the combination is there, when compared to normotensive with diabetes, all the things parameters are high, like all-cause death, CV death, any CV event, MI, stroke and CHF. All things are increased. So, addressing both issue is very important. So, CV mortality risk doubles with each 20 to 10 millimeter of mercury increment. You can see how the things CV mortality is increased with the blood pressure reading. 20 is increasing, the risk is also increasing. So, each millimeter plays an important role when we are clinically addressing. We always think what will happen in 2 millimeters of mercury reduction. We always, it's a general mentality, we always think what will happen in 2 millimeter, 1 millimeter. All this data shows each millimeter of blood pressure reduction is very important and very crucial in preventing the morbidity and mortality. So, diabetes and hypertension predisposes The common risk factors are these four: insulin resistant, dyslipidemia, genes and obesity, diabetes and hypertension. You can see a circle here leading to atherosclerosis, endothelial dysfunction, vascular inflammation, fibrosis, arterial remodeling, leading to microvascular and macrovascular disease, ultimately leading to the cardiovascular disease. So the hypertensive diabetes, you can always say they are the partners in crime because they are linked to each other. So the pathogenesis of hypertension and diabetes, they are like brothers and sisters. You can see, looks a complicated picture, but if you can see, the top one is the visceral adiposity, insulin resistance in the hypertension. We can see how the vicious cycle is there between hypertension and diabetes. So the putative mechanism whereby diabetes and hypertension cause vascular disease, you can see that both things causes hyperglycemia, RAS system, immune activation, oxidative stress, inflammation, mitochondrial RNA, all this combination leads to macro and microvascular disease. So what is the special characteristic? This is an important slide to know our hypertension in diabetes, how it is different from other associated diseases. The lack of nocturnal dipping, high nocturnal BP, greater early morning surge, greater salt sensitivity, higher systolic blood pressure and isolated systolic hypertension, greater resistant hypertension. The goals of therapy, according to both, you can see many guidelines are there. This is an important line we should remember. Come to American College of Cardiology, European Society of Cardiology, International Society of Hypertension, ADA group, all recommend the control should be less than 130/80. These are always a question. What should be the blood pressure control? Earlier it was 140/90, but now it is 130/80. It should be always 130/80 when it comes to diabetes and hypertension. So why it is so important? With every 10 millimeter decrease in systolic blood pressure, risk of diabetic complication is reduced by 12%, associated mortality is reduced by 15%, risk of MI is reduced by 11%, and microvascular complication is reduced by 13%. So when it comes to guidelines, I'm sure it's a confusing thing. There are flood of hypertension guidelines. So it is always, as a clinical practitioner, which is tough to believe which one to follow. But it should be a general consensus. When you think your goal of hypertension should be less than 130. You can see here, starting from 1977 in the top left, JNC report, there are so many guidelines here. So among that, a position statement from ADA is also be given. So you follow over one single guideline that makes your life easy. So if you take ADA guidelines, you can see this is a beautiful chart to say when to start, what to start, and what decision you can take. Simple, if the blood pressure is more than 130/80 and less than 150/90, start one agent. If albuminuria is there, start ACE inhibitor or ARB. Otherwise, you can select from CCB and diuretics. Then if the control is not there, then you can appropriately select. Coming to the other part, when the initial blood pressure is more than 150/90, you can start two agents. If albuminuria is there, start ACE inhibitor or ARB and CCB or diuretics. If there is no albuminuria, you can select two out of three drugs. Then once the BP is not under control, then you can see the other drug, the combination, permutation and combination you can do. Ultimately, you can, if all the things are not responding, you can consider mineralocorticoid receptor antagonist as well. So this is the flow of chart which tells you what to use and when to use. Our own RSSDI, where I am the executive committee member, the recommendation for diabetes patients with hypertension, you can see first, these are the following drugs which can be used: ARBs, ACE inhibitors, CCBs and diuretics. Among the ARBs, the preferred is telmisartan. AC can also be used when patients are not responsive to combination therapy. CCBs, cilnidipine or amlodipine. Diuretics used in cases of resistant hypertension and elderly patients. So first line agents in combination therapy used in patients with existing CVDs, CKDs and other complication. After all these drugs, we always think the bottom line is lifestyle modification for all the patient concerned with weight loss, healthy diet, that is DASH diet, that is the stop hypertension diet, where we have so many parameters you have to consider. Sodium restriction, potassium restriction, and most important, the physical exercise, the aerobic exercise, dynamic resistance, isometric resistance, and also moderation in alcohol intake. So all these parameters has to be done. It is not only the question of starting some medications to all the patient. The education about lifestyle management is very, very crucial about diet and exercise. Pharmacological, as I discussed, the preferred drug of choice is ARB, then the CCB, then the thiazide diuretics, depending upon the condition of the patient. ARBs for the management of hypertension is most preferred. A brief about ARBs, I am sure all of us know this, but just to recollect ourselves, it is one of the most widely used antihypertensive drugs. It reduces cardiovascular and cerebrovascular and renal complications, minimizes morbidity and mortality, safer, tolerant and more efficacious than the AC inhibitor for BP control, have maximal renoprotective effects compared with other drugs, risk towards side effects lower with these agents compared to with the AC inhibitors, administered in combinations with other agents such as CCBs, thiazide diuretics, to reduce the risk of CVDs and renal disorders in patients with diabetes. So telmisartan, I am sure, it is one of the preferred drug. I am sure we are using left and right, but few things you can see. Telmisartan and losartan are the most effective choice to reduce CV risk factor. Telmisartan is selected as the first line ARB agent because of its beneficial impacts on fasting blood glucose and insulin levels. In those at higher risk of stroke, this point is also important, those at higher risk of stroke, losartan is preferred because of the data availability. In patients with history of atrial fibrillation, telmisartan also can be considered. This is the recommendations. CCBs, among the CCBs, cilnidipine is the preferred one because it is a novel, effective and safe CCB established for its renoprotective effect. So what are the evidence of benefits? Age-old history of evidence is there since past 25 to 30 years, like UKPDS, HOT study, advanced BP. All these studies have demonstrated aggressive blood pressure control is even just a matter of 10 millimeter difference. You can see the beneficial is there in reducing morbidity and mortality. These are the evidences which shows good control of BP is the need of the hour. So multiple medications are required to achieve BP control in clinical trials. You can see accomplished trial, HALAT, HOT study, ACCORD, IDNT, renal, ABCD, UKPDS, MDRD, ASK study. All this shows you can see 1, 2, 3 drugs. So majority of the drugs requires multiple medication in a long run for the proper control of the blood pressure. So ladies and gentlemen, the take home message from my talk, diabetes and hypertension often coexist, leading to synergistic increase in the risk of cardiovascular complication, including stroke and kidney disease. Regular screening for hypertension is crucial in diabetic patient as it often develops silently without noticeable symptoms. The treatment goal for blood pressure in diabetic patient is typically less than 130/80 according to the most guidelines. Evidence suggests that achieving the target can substantially reduce the incidence of cardiovascular events, including MI, stroke and heart failure, thereby enhancing the patient outcomes and quality of life. Combination therapy involving 2 or more antihypertensive agents with complementary mechanism of action is often required to attain optimal blood pressure control. So in diabetes and hypertension, it is mandatory that cardiorenal protection is accompanied by an early intensive management. This means to harmonize the gluco and cardiorenal centric approach of the disease management. An early combination of anti-diabetic and anti-hypertensive agents is a logical solution. Try to fill those gaps that commonly observed between guideline recommendation and what have been seen in routine practices. Ladies and gentlemen, good physician always treats the disease. The great physician treats the patient who has the disease. Thank you for your patience hearing.